A warm welcome to everyone. We are a lot today, all together. Welcome to the interactive section organized by the Global Health Cluster with the support from the READY initiative. I am Donatella Massai. I work for the Global Health Cluster COVID task team, and I will moderate this session today. Today, we'll look at the tool. You see it on the screen on the left. Ethics key question to ask when facing dilemma during COVID response in humanitarian setting. But we will also discuss several other aspects of ethical dilemma related to COVID response together with our panelists and with you. Now, before diving into the content and the presentation, to warm up, we are going to do an exercise. I don't know if you know, we're gonna use Slido. So this is, I'm gonna show you. So grab your phone, if you have a smartphone, I guess you have. Put slido.com, as you see here on the left on my screen. Can you see it? And then when you open it, it asks, you see exactly this screen, like on your phone, what you see on my screen on the left. When it say enter the code, you put ethic 1, no capital, no space. Ethics 1. I think you'll see in the chat box also. And then there are a couple of questions that will just warm up and know each other a bit better. If you encounter any problem in reaching slido.com, I hope you don't, because it's much fun. But if you cannot, please answer the question in the chat box, and somebody will get your answers. So I'm gonna stop sharing and getting. Look at this. Whoa. A lot of Washington. I promise I didn't put it. Washington, Atlanta, Canada, South Sudan, Turkey, South Sudan, Switzerland, Ireland, Dakar, one of my preferred places, Zimbabwe, Japan, Pakistan, Syria. Wow, guys. Is anybody encountering problem? Is it easy? Brazil. Thank you, amazing. We're gonna go on the second question, if you're ready, which is, are you familiar with the tool by the Global Health Cluster, the tool that I have shown before? And you should, yes, quite clear. No, yes. I really hope that the yes will win, but go vote, vote. So if people do not know, this is a great occasion to represent Eva. You're gonna have, and we're gonna have a lot of questions then. Wow, 32 person. Is there any in the chat box, Paula? You're muted.
No.
Okay, so everyone feel pretty comfortable with the. We have 34, we are 61, so about 50% answer. So we can go back to our presentation. So Slido worked. So this is the tool. I was the one ethics key question to ask. This was the tool we were asking for. It was really, really nice. It's even my first time on Slido. No, not my first time, but Slido, I think it's good. I hope you enjoy. We're going to use it later on for other question and discussion. Before we start with the presentation, let me provide some housekeeping information. They're really important. The session is recorded, and the link with the recording can be shared if you are interested, if you need it, from tomorrow on. The session is, as you have seen already probably, is in 4 languages: English, French, Spanish, and Arabic, and you can choose any language, the language you prefer. I will ask the panelists, but I see them already on video, to be on video at least when they present. And then again, for the course of all session, if you have questions, please use Slido, and instead of ethics 1, you put ethics 3 in the, when you open the slido.com. And in the course of the whole session today, you can ask questions, and we will ask them, we'll answer them at the end in the question and answer session at the end. But if you have any burning issue, question, please do not hesitate. We can stop. Otherwise, we'll go after at the end. And I think we are ready now to present the first panelist. Let me introduce Professor Lisa Schwartz, who is the Arnold Johnson Chair in Healthcare Ethics at McMaster University. Professor Schwartz is also member of the MSF Ethics Review Board. Welcome. I stopped sharing, sorry.
That's okay, good, thanks. I'm going to try to get my slides up. We had a bit of a challenge with that earlier, but hopefully I'll figure this out. So right now you're probably seeing a clear screen, is that right? Yeah. And if I begin my presentation, what are you seeing now?
Not the full screen.
Okay. That should work, yeah?
Yes, perfect.
Good,
thank you.
Okay, thank you. And thanks everyone. First, I want to say thanks to Donatella and team for all the work that you've done, and to acknowledge the partnership, the collaboration with IVA that's brought us to this point. And today, like I said in the chat earlier, I think what I'm going to do is very simple for a start, but I think where the complexities will come in is when we're discussing the case study and the realities, I think, for all of you on the ground. So although I'm affiliated with the Ethics Review Board at MSF, and also do work with WHO on community engagement during COVID response, I am an academic most of the time, and my background is in philosophy. So I'll rely on all of you for the contributions around the realities of things. So we're looking at ethics in pandemic response, and I think it hasn't been easy for anyone. The pathway to making easy decisions or clear decisions is never something that that was going to be possible from the start of the pandemic. I think we knew that there would be difficulties, and there was a lot of panic at first. I think now we've begun to be accustomed to some of those challenges. But as somebody early on Twitter, a colleague said, I'm not even sure which one it was, she said, you know, things are going to be bad when they start calling in the ethicists. And so I think that's where we got to, is that as ethics consultants, we suddenly became very busy and very popular. Now I can't seem to advance my slide. There we go. So some of you probably heard this term before. I'm sure it's not a new term to most of you, the notion of a syndemic. So a syndemic initially, I think, was meant to describe as the CDC puts it, the synergistically interacting epidemics. So when epidemics overlap with epidemics. But the interesting thing about a syndemic is that it really highlights questions of justice and actually the factors that create injustices that go beyond the biological and into the social factors. So I became interested in that idea of syndemic at that point, where we were thinking not just about who could do well clinically in during the pandemic and due to COVID, but also what were the factors that were making it possible for some to fare better than others. And that included things like access to healthcare, access to good information and education, and then of course access to vaccines. And we've seen the disparity locally, but globally has been almost, well, I think probably unbearable for most of us to watch. And I think that the idea of syndemic is particularly appropriate as a concept in humanitarian settings because of the limitations that we live with all the time. There's always a crisis at the same time as other kinds of issues. And for the most part, questions of poverty, of displacement, natural disaster, lack of resourcing, all of those things come together to create not just the medical response that's needed, but the global humanitarian response. Lisa Tessman is an American philosopher. She referred to these things as imperfect moral contexts. And as a concept, I guess I think of it often in the humanitarian setting, that these imperfect settings that have a tendency to make it hard for us to do the right thing. And every time we feel that we're looking at the right direction, something thwarts it. Some obstacle comes up, some moral imbalance. Sorry. So one of the first things that happens, I think, is people start to feel frustrated, at a loss. They think that they've lost control over the resources that they do have, like the personal resources for doing the right thing. In medical ethics, a lot of the times the doctors will rush to, first their medical texts and their guideline statements and to do what they think is the right thing to do. Other times they look to the law, hoping that the law and things like the international humanitarian law, international health law will help them solve problems that are, that are confounding, I guess, their medical understanding of the world. And then they realize that there's more to it than that there are subtleties and nuances. So we recognize that we've got an ethical issue when the right thing to do is not obvious, or when it compromises some other significant commitment that we need to make, like a duty of care to everyone, as opposed to just those people who might be able to do well. And so we're stuck in these imperfect moral contexts where there's a feeling that no matter what we do, we can't avoid doing some harm, that the moral wrongdoing is hard or even impossible to avoid. And we'll look at some case studies in a minute that I think bring this to reality. But as you're hearing this, I wonder if some of that is resonating with you, those moments where you thought, I just don't know what I can do, or I don't know where to turn to, or how to respond to this question. We're lucky because to a certain extent, we've got, I just noticed the chat come in. To a certain extent, we've got some tools, I guess, which we rely on, and these are the theories of ethics. So I called this slide Philosophy 101. Some of you are probably familiar with some of these very Eurocentric, I admit, theories, but they're theories that I find sometimes help us guide us by either illuminating or showing us sort of a new way to look at the problem. So you're probably familiar with utilitarianism. Utilitarianism is particularly concerned with outcomes. What is it I'm trying to achieve? What am I hoping to do? Often it's associated with sort of the greatest good for the greatest number kind of reasoning. And when you're going into a disaster setting, particularly, there's this desire to quickly save the most lives possible. So utilitarianism points us in that direction. Deontology, which is probably less familiar to some people, it comes back from Immanuel Kant. Deontology is focused on duties. In fact, the word deon is Greek for duty, so it's duty oriented. And that means that sometimes we have things that we want to do or outcomes we want to produce, but we also have our duties that guide us, duties of non-abandonment, for example, duties of care to others, particularly when as humanitarians, you enter into that field, you immediately acquire some sort of a moral entanglement, which is a responsibility or a duty to other. The reason I like to talk about these two is, in my classroom anyway, in Philosophy 101, sometimes look at these two as potentially conflicting. So if your duties, if you know what your duties are, what you're responsible to do, because you have the guidance, you have your professional organizations, you have this responsibility to others, if that doesn't coincide with creating the best outcomes, let's say, trying to preserve the most lives possible, then you have a proper moral dilemma, right? So I know what I'm supposed to do, but if I do it, it's going to cause some harm. Or I'm trying to create the best outcomes possible, so I might have to do something that isn't necessarily aligned with my duties in order to achieve it. So we look at those two, these duties and outcomes, as a useful way of thinking about where am I in the problem? Am I looking at my duties and seeing that they don't correspond with possible outcomes? Then I've got that moral dilemma. Another theory that's well known, and I noticed Dr. Gayat Hussein is on the call with us. So we've been having a debate on Twitter about principalism. Not really a debate, but I think we were recognizing that principalism is useful, but people have a tendency to rely on it very heavily. And it's great because what principalism does is it identifies principles or values or statements that we really want to believe in and that we cling to. So we might say in healthcare, often that's autonomy, non-maleficence, beneficence, and justice. But in, of course, the humanitarian setting, we have things like neutrality, humanity, impartiality, right? These are principles that are stated that we, as professionals, have to align ourselves with. The problem with principalism is that while it gives us a good common vocabulary and a sense of what's important to people, it doesn't tell us whether we've A, got the right principles or the only principles that we should follow, or B, very importantly, it doesn't tell us what to do when two principles conflict. So is there a hierarchy? Should one take priority over others? And we'll see how that might play out in the context of the case studies in a little bit. Very importantly, though, ethics doesn't offer all the solutions. And I was apprehensive coming on this call today as I was preparing, because I can't tell you the right thing to do. And particularly when the right thing to do is really hard to find. I'm not sure if any of the theories will give us, clear-cut, easy answers. They give us tools to use to think about, but not the pathway to the right answer. And so in those circumstances, when the answer is hard to find, when the right thing to do is hard to identify, we also rely on something else we call procedural ethics. So process is really important, and how we find the right process and establish that process can really help to make sure that people feel that they're included, that their voices have been heard. It allows for better buy-in and gives you other possibilities that you might not think of when you're alone. So process, as I've said, is important when it's a collective approach, when it involves things like inclusivity and is oriented towards equity. And the toolkit, and I have to say, I'll just point out that it's not going to be easy, particularly the inclusivity part. I hear people say, how do I find out whose voices, who should be included? It may not be easy, but like I said, I don't think your work is ever easy, and I admire your persistence as you slog through that. So this might just be another factor, but you also have community contacts, you do your community integrative work, community engagement, and probably even have some community advisory boards that could help inform some of this difficult decision making. And I urge you to rely on them the way that we've been doing in the randomized controlled trials that WHO is leading, that we're leaning heavily on existing community advisory boards to help give us insights on what works and what doesn't work. As just sort of foundational questions, I always come back to these ones. You know, the first question of whatever it is that I'm going to do as I'm making my plans, who could be harmed by it? And we might think about the immediate harms to people who might not get something, but also the long-term harms, the kind of disinterest or disenfranchisement that happens when a group of people are told you're not going to get your way this time. And I think we're seeing this heavily in the, you know, anti-vax kind of orientations, the distrust, I guess, to healthcare, that sometimes it's because people felt that they haven't been heard or that their concerns haven't been adequately met. So we want to know who could be harmed and how can we mitigate those harms. We also want to know who's going to benefit. So not just looking at the harms, but are we adequately sharing the benefits that could come from the decision itself? And is it always the same people who are benefiting, or should we be thinking about expanding that base of benefits? And then we can also ask ourselves the question, if we don't act here, if we don't do anything, is that okay? Sometimes it is, and sometimes it's not. So given the case study that's coming up and some of the difficulties that we've been talking about, particularly around equity, I wanted to share this quote with you, which is one that I use over and over again with my students, and that I keep coming back to. It's from 1967, and forgive me, it's, you know, it's kind of Anglo-centric, and it's also sexist in the language, so I'll just alter that as I read it. M.H. Papworth, in the realm of research ethics, said, "No physician is justified in placing science or the public welfare first, and their obligation to the individual who is their patient or subject second. No doctor, however great their capacity or original their ideas, has the right to choose martyrs for science or for the general good." And I think we can just as easily substitute, you know, politician or humanitarian actor for physician in this case, and knowing that we don't have the right to choose martyrs for the general good. So always thinking about those interests. I'm just so glad that Eva had come to us. Myself and Dr. Matthew Hunt, we contributed to the development of this tool that really was led by Eva and the team at the Health Cluster. And I'm glad we get a chance to share it with you, because it provides both a process as well as key information for making decisions in this field. And these are some references and some resources. So thanks very much. And if you're interested in finding out more about humanitarian health ethics, you can find us at the website there. Right. Now I'm going to try to stop sharing.
Thank you. Thank you, Dr. Schwartz. Thank you for the incredible presentation. Now, if you're not tired yet, we're going to do another interactive exercise on Slido. This time, a couple of questions about your own experience. So you still go on Slido and you insert ethics too. I think you can see in the chat box. So the first question is, in your work, have you faced a dilemma? Of course, we refer to COVID-19 response, where you had to make a decision or follow a decision that you thought still was unfair or unjust, or had some kind of negative consequence, but was still probably the best and only option to follow. Wow. This confirmed that this kind of online session and webinar are important. I don't know, this is what is telling to me. wait a few seconds more, although we are a bit late. Just want to give the opportunity to everyone to contribute. And the second question is, can you describe, so a couple of words, doesn't have to be long, some dilemma you have faced? I think you have seen in the presentation of Professor Schwartz some of the issue, and you have most of you have experience, workforce management. We'll have a brief presentation on that, inequity. Priority group for vaccination, of course. No mask for, yeah, I know IPC material has been an issue from the beginning. Policy restriction, blind leadership, triage. And pretty much any resource allocation decision. Yes, I'm almost like this one, summarize all of them. Pandemic fatigue has an excuse, but not only it is a fatigue, it has been, and it is very hard. Distribution of small remote population having, a small population having big outbreak. Yes. Wow, great. Thank you. So COVID isolation, yeah, I could stay here forever, but you can keep, I mean, this is still open, so you can stay on ethics too and keep posting we're gonna analyze at the end, and hopefully with other information, we're gonna make all what you share with us important information for how to do better next time and how to be inclusive. Obligation to subordinate, to keep all the time put on their mask, sometimes with sanctions. Mm-hmm. It's true, some countries. Mm-hmm. I would say, so you can continue to post your question anytime, reaching those left behind. Yes, this is almost our work all the time in humanitarian setting. Thank you so much for it. It's really great. Thank you for your, and so now we see already the presentation. We have now with us, everybody knows her, so I don't almost need to introduce her. Heba Pasha, Global Health Cluster COVID Task Team Focal Point. And she will present the tool that we have seen before, key question to ask when facing dilemma during the COVID-19 response humanitarian setting, a people-centered approach. Please, Eba.
I'm trying to unmute. So we've gone through some, and I hopefully have unmuted now, but we've obviously all faced lots of dilemmas during COVID-19 response, or humanitarian response in general, so I won't go through that. But as we go through the tool, I just ask you to focus on one of those examples that you've personally felt or experienced, and then use that for the steps as we go forward. So just something about the tool itself. It was developed by people who already developed standards in humanitarian settings. So Sphere, heavily involved in it, co-wrote this. Global Protection Cluster co-wrote this. So these are people who, talk about people-centered approaches, accountability to affected populations. We have a position paper on quality of care. It aligns through all of this. So these really aren't new principles. We're not coming up with anything new. It's just with what we already have a commitment to doing in humanitarian response. How can we do that when we're facing a quandary? Quandary is an understatement. I'm trying to go ahead. So why should we use a tool? And Lisa's already said this, but it's really, and we know we do this every single day in humanitarian response. You guys, frontline workers, do. We need to maintain public trust, especially when we're doing horrible, hard things. We need to make sure whatever we do when we face that situation, that it's consistent and equally applied. What I mean by that is it's not going to change because it's me one day and my friend another day. It's not going to change. That decision or outcome isn't going to change because it's someone rich or my family that are walking through. It's not going to be dependent on ad hoc things, but we have a consistent, systematic approach. So we can trust in whatever that system is. We have to be transparent. We have to engage communities. But of course, they have to be allowed to challenge our decisions as well. And if there's one thing that we must walk away from this webinar is that frontline workers should never be left alone to deal with a horrible situation. That is absolutely, that's clear in CHS standards, organizational duty of care to our staff. But we know there's burnout, we know there's distress, we know people are having to make these horrible decisions and they need that support, but they shouldn't have to make these decisions by themselves. So this is kind of like the 8 steps within the toolkit. It comes from other toolkits as well, which Lisa's been heavily involved with, but we really just made the flavor it in line with SPHERE and accountability to affected populations, about humanitarian principles, and we just kind of incorporated that kind of language. So number 1 is it an ethical dilemma? I mean, if out of all of your response options, one of them is pretty good, that's not really a dilemma. That's like, okay, well, there's lots of options, but there's actually a good outcome here. But if all your possible scenarios are horrible and cause some kind of harm or inequity, then, you know, it's an ethical dilemma. You need to work out what are the pros and cons in each, what are the ethical principles. You don't have to go down a very geeky line, but, you know, am I helping the individual or the community? What is the rationale behind all of this? And very importantly, given our privilege, our status, what are our own biases compared to the community? Who is actually having to make these decisions, address the dilemma? Is it your frontline healthcare worker by themselves? Is it everyone? Is it the health cluster? And obviously from the health cluster point of view, we are a community, we are health cluster partners, we are a sector, we have a collective responsibility. Is it individual organizations, Ministry of Health? Who is it? Who's having to make those decisions? And then again, as Lisa said before, who's being affected by it? Are certain groups being affected more than another? And if so, how or why? What is the community perception about this dilemma? And this is really, really critical, that we probably, I don't know, is the toughest of them all. How much are they really informed or understand what the different options are? Do they really understand what the dilemma is? If they're being rejected from healthcare facilities for COVID-19 because there's no beds, do they understand what those issues are? People are being turned away in India, Bangladesh, many countries when we have the Delta wave, first wave. Do they know why they were being turned away? Are they, what do they think about all these different response options that are available? Do they think some are actually acceptable? Do they think it's not acceptable? Do they trust us? Do they trust the healthcare provider? Do they trust the government who's making these decisions? And importantly, I always call that democracy, but that's my own cultural bias. Are they able to engage in this process, the discussion we're having about whatever issue it is, and think about that issue that you've just written about? Were the community able to engage in discussing what those options are and what they think works or not? So now we've kind of defined what the situation is, determining a way forward. Again, the only key takeaway I really want from all of this is frontline worker cannot be left alone to deal with the situation. So when they're facing it, even if it's in real time right now, who can help in that situation? Well, within the organization, obviously we all have a duty of care. So if there's one worker, they should be able to have a supervisor they can talk to. They should be able to talk to the country team, HQ, whatever it is. But within the organization, you all have a responsibility to support dealing with the dilemma. There may be other organizations, probably other organizations facing the same issue. And as such, as a health cluster, and this is me as Global Health Cluster, we are saying, we also have a collective duty to be able to have that conversation and come up with a position on it. Do we need further advocacy with perhaps the humanitarian country team or the national authorities? This is also avenues that we can do. But of course, throughout this, we need to be engaging the communities. So what is it that we need to do? number one, we need to create that environment to collectively discuss that horrible situations are presenting to us, and we need to come up with a way. We need to allow for that environment to be a place where we can all at least discuss it. Again, going back to the same thing, this is going to be on repeat. If someone is facing having to make a decision frontline and in the immediate moment needs to decide, they really need to have someone, a point of contact, senior within the team, who they can have this conversation with. It shouldn't be an individual discussion ever, even if it's about case management protocols, if it's about closing down clinics, if it's running out of bed suddenly at 4 p.m. or 11 p.m. at night, whatever it is, there needs to be that mechanism within the organization, within us, to be able to reach out for support. But again, especially in COVID-19, especially in humanitarian response, we're often all facing this together. So organizationally, we have the options of creating SOPs and doing further advocacy. I'm going to try and go through quick stop check. Once you've decided how you're going to do this, do you need any more information about vulnerable groups, people at risk? I'm trying to whisk through this because I want to get to the case study afterwards, which Sudan will be doing. But again, what are these? How can we collectively determine an appropriate solution? So one way is, of course, creating a working group, and South Sudan, the health policy coordinator from South Sudan, who was previously in Cox's Bazar, will go through that with you. But together, you need to be reviewing the situation. Together, you need to be analysing those pros and cons. And together, you need to decide on a best option and be super honest about who's going to lose out in this. Because by understanding who's going to lose out, you can, hopefully, you might not be able to, put in some mitigation measures for those. For example, those who are being turned away from healthcare facilities. What can we do for home-based care? What can we do for home-based palliative care? What does that look like? Do we need other sectors? Do we need other people? So being honest about that decision is the most important, so that you can decide those contingencies afterwards. So what are the next steps, other than, you know, making sure you use the SOP and the advocacy? Throughout this process, we need to be engaging with those communities, understanding how they're feeling about it, understanding their, incorporating their feedback into your decision making on what the response option is. But also have that feedback mechanism. They have the right to challenge us on whatever the decision that is. And this is a basic AAP principle. But the second big important thing is we need to make sure our frontline workers who may be distressed by what they're having to, the decisions they're having to either follow or make themselves, we need to make sure we have an environment and the skills and capacity to give them that support. So I'm just going to leave it there and hand over back to Donatella.
Eva, thank you so much. Thank you not only for your presentation, but for your leadership in developing this tool. Thank you. We have different options. So I will now briefly, promise, very briefly, because we are very late and we want to have space at the end for questions. Dr. Aisha Malik was sick today, so I will briefly introduce mental health and psychosocial support to the healthcare workers. It's probably somehow already included partially in what Eva has presented, but let's speak about the risk for healthcare workers' mental health during COVID-19. I think you have already mentioned in the list of the things you put in Slido, but let's mention a few of them. It's higher demand in the work setting, of course, increased witness to suffering and deaths, very hard, increased volume of clinical services leading to overburdening. I think you have almost all experienced this. Tension between public health priorities and patient wishes, and Dr. Schwartz present about this, and overall a situational anxiety. We all are at higher risk of infection, as has healthcare workers, our family, and our communities. Healthcare workers' mental health should be prioritized to be able to support their capacity to work, both in the long term, but as well in the short-term crisis response. It's almost like the mask in the airplane. We have to treat and make sure our health staff is healthy and mentally fitted to be able to work and support others. Another important concept, and repeat, Iba has already mentioned partially, is what is the management role? And I think in this call, we have a lot of managers, and I'm sure you are doing this, or if you have resources, part of it. And the manager should assess and minimize additional COVID-related occupational psychosocial risk for stress, ensure access to and provision of mental health and psychosocial support for healthcare workers, if it's not in place, promote a culture where healthcare workers feel comfortable in seeking health. This is another very important thing. Train health leads in basic psychosocial skill and regular supporting monitor of staff and their mental well-being. Very often we give as a grant that healthcare staff is able to support mental health, but it is not, they need training. And I repeat one thing because I really think it's important, is the concept that Iba has repeated 2 times, and I will repeat a 3rd time, is that no frontline workers should be left alone to take difficult decisions, and everybody should know where and how to get the needed support to do better next time, or to do better while you are working. I conclude here my presentation, I promise, short. And I would like now to give the floor to Dr. Mukesh Prajapati, who is the Health Cluster Coordinator in South Sudan and was previously in Cox's Bazar. He will present Addressing Ethical Dilemmas During COVID-19 Response in Humanitarian Setting, a case study in Cox's Bazar, Bangladesh in 2020. Please, Dr. Mukesh.
Thank you so much. Thanks, Donatella, Professor Lisa, and Eba for excellent presentation. You make my life very easy to just go through with what we passed through and how we followed unconsciously or consciously these principles, or where we haven't followed. I'm trying to. It looks like I don't have access to share the screen. Can I host? Oh yeah, that's great. So let's go to first slide. This is okay. So as Donatella mentioned, that my name is Dr. Mukesh Prajapati. I'm a cluster coordinator, currently based in South Sudan. I used to be in Cox's Bazar, Cox's Bazar, we said the health sector. When COVID-19 struck, I used to lead and coordinate the health sector together with all partners, WHO, and other colleagues, also with at the observers, MSF, and Red Cross family. Next slide, please. What I'm presenting is already there in the guidance note, which Eba has described briefly, and exactly where we were also looking at when it first struck. I still remember 8 February when we met key organization together to how to deal with the disease, which we don't know. We didn't have a guidance. We didn't have any how to prevent, how to approach. And during at that time, right from there up to the middle of the 2020, we were in long dilemma, individual versus population healthcare when there is no guidance or little guidance available. Lockdown at that time, when I'm talking about first and second quarter of 2020, it was very new. No lockdown, mixed, localized lockdown. Which mask? When we started 8 February, when preparing for largest refugee camp in Cox's Bazar, we started preparing for COVID-19. We had a very limited N19 mask and surgical mask, a few which has been procured by in a kits to provide regular services, and we didn't know how to make a cloth mask, and then PPE were almost not there. Those it was very few in order to deal with, thanks to pandemic preparedness, that projects which we used to have a few PPEs. And so during that time to make a decision was not easy. This time we can say that, which mask to wear, everybody knows. At that time, which mask to wear in midst of spreading infection, it was not easy. Where is a patient's choice? Some patients totally decline not to even taste, not to go to the service, and then during that dilemma, that how we continue providing services and prevent COVID-19 infections. Prioritize treatment versus spreading of the disease, how to convince community that what is required in order not to treat also, but also to prevent spreading infection. And when response started, middle of the 2020, what about essential services, immunization? No one was taking services, and it was almost like stop services, elective surgeries, deliveries, and what precautions needs to be taken. It was not easy time there. And finally, health and livelihood, what to choose, health or to have a regular income. Next. And that's how we face dilemma in world's largest refugee camp, where around 750,000 population was housed in crowded conditions in Cox's Bazar, where health sector was leading health along, and other sectors were under intercluster coordination, intersectoral coordination mechanism. We decided at that time that health sector, all response will be under the leadership of health sector. And situation was that when we came into this dilemma, and this case study what describes is that we were expecting overwhelming capacity. We had a national protocols which requires all patients to be admitted, suspected, confirmed, all patients. Then we have a community feedbacks. Some are not willing to use community facilities, even if they are very sick. There is also host population around 500,000 more, 700 here refugees, 500 more, close to 1.3 million population. And host population, home isolation was a bit easier than camp. And protocols is a national protocols which apply to everyone. So how to differentiate between now for refugee population and host population? Next. And this was dilemma, that what is the best way to manage patients, how when we overwhelm with the situations where SARI facilities are not enough, when all SARI is SARI, severe acute respiratory infection treatment beds, when all beds are full, how we deal with this this large influx of the patients. And at that time we were preparing, we had almost like 750 beds in 13 centers, 12 to 13 centers were ready. We were expecting, as per having using a different models, we were expecting triple number of cases. And limited resources are available, and we have to see that what best we can provide, best treatment can be provided. It's not individual, but to the communities, and both host community and refugee community. Next. And then that's what dilemma, if you come across this guidelines and you read beneficence in terms of for the patient, beneficence for the population, utility, doing good for the most of the people, and also liberty, looking at patient's choice, community's choice. So each and every aspect of this ethical principles has been challenged, and in midst of this we have to take decision. Next, so we have now options. We had only 3 options available, and then here, like, we admit all patients irrelevant of the severity, and when in hospitals all beds are full, then we will not admit any patients, even it is a mild, severe or critical. Second option was to prioritize home-based care for mild and moderate, and we admit critical cases. This is about admitting patients in COVID-19 treatment facilities. Option 3 was as with option 2, but also prioritize severe cases to be to have home-based care depending on risk factors and on the level of support needed. So we continue option 2, but then also treat critical patient at home. And this is because it is not that we didn't want to treat, but then patients' beds are not available. What to do with severe cases? In this context, then we choose, next slide, please. We choose option 2. Where and then choosing option 2, we finalize the SOP, standard operating procedures, among ourselves, and then we made a decision, collective decision at that time, that if treatment centers reach 75% of bed occupancy, or 1500 suspected cases. So this is like we made ourselves a definition of that, when to choose, do a different option. And then we will choose that home-based care, we will provide mild and moderate, and we will keep patients, severe patients in hospitals. Now, in order to have this decision implemented, we have to do preparations, and these mitigations, what we have done is provide provision of supplies, home-based care patients. So we decided, we agree on the kits to be provided at for the patients who will be treated at home. We agree with community health care. We prepared a home-based care treatment guidelines for community health workers. We trained home-based care health workers, and ensuring the supervision from health facilities medical staff. So ensure that workers follow the protocols, and we treat and we identified patients, severe patients who required treatment. This is also like we engage communities through our community working group. We used to have a community communicating with communities, CWC, to ensure that what we are going to do right now, and when treatment are not available, or when we have all beds are full and our capacities will be exhausted. So these mitigation measures we have taken in advance. It was a long process, long investment, but that helps to win the confidence of stakeholders, including government. Next. So briefly, what lessons learned for us during at that time? we understood that, recognize the ethical dilemma, unconsciously or consciously. You might be, you don't know, but you are facing that what I'm doing right or wrong, and if wrong, then what are the ways to make it right. Have evidence-based options, discuss different options with stakeholders and agree upon the options, available options and best available options with time, place and person. I usually say context. So it is a contextual evidence-based options. Discuss and agree options with various stakeholders, which also include health sector, cluster, government, also discussion with communities, consult stakeholders, including communities, undertake mitigating measures depending upon your choice of options, and always monitor and adjust response accordingly. Finally, I have a last slide based on South Sudan recent context, which is also giving you that some next slide, please.
Dr. Mukesh, we are running out of time, please.
Okay, so this is the last one I am saying, and then many of you, including myself, we are paying for PCR test when you are not sick. And this is also like, okay, I am not sick, but I am paying. Why I have to pay for test? And that's what happening in here in South Sudan airport. Some of us have to pay for the PCR, and it is like a randomly selected patient, randomly selected travelers. That was not the Ministry of Health WHO guidance, but National Task Force, which is highest body, wanted to implement. Finally, we negotiated and we came into the agree to have a monitoring mechanisms who will choose the patients, and then we change testing not from PCR but to RDTs, and it is free of cost. Thank you. Over to you.
Dr. Mukesh, thank you very much for the presentation and sharing the experience. Now we have to revise our schedule. We are late. We were starting the question and answer session with some with the Slido at ethics. At ethics 3. So because we don't have a lot of time, so you can post your question, your question here. Probably you have already done. There is one question. I would suggest that this Slido ethics 3 remain open. You can post question if you have, or if you want to stay a few minutes more, we are here available for answering your question, and we will keep the question and then answering them in written and sending to you in case we have questions that get unanswered. So I think this was more like a comment. It does resonate. I think it was during the presentation of Dr. Schwartz, and it reminded me the phrase "a wicked problem," and I think you have spoken about that when the mitigation itself causes some harm. I think if you, Dr. Schwartz, if you want just in few minutes or seconds, just give a comment on this, and then I think we need to close.
Yeah, I mean, I think that's exactly right. It is a wicked problem, and we do have challenges like that. I guess sometimes we call them the impossible choices, or wicked problems, or tragic choices. And I think the mitigation strategies and the strategies that we've just heard described by Dr. Mukesh are so many of the ways that we can help manage it. And I think, as Ebba said, don't try to do it alone. That's the key. You don't have to do it in isolation. Look for help, look for support, and look for guidance, evidence-based and social guidance. That'll make a big difference. I don't know if anyone else wants to add to that.
Thank you so much. Is there anybody who wants to ask other question? Otherwise, I think we We are over already a few minutes. We are gonna close. I hope you find this session interesting. It has been a pleasure for us having all of you with us and interacting with us and sharing your experience. I just, the last things in the chat box, you'll find a survey for this webinar in which you can answer to few questions. It will take 3 minutes. So please, if you can do it now before you forget about us, or do it as soon as possible, and please send to us. It's very important because we want to improve and your comments are very important. Thank you so much to the panelists and presenters. Thank you for the organizer, the translator, and all the participants. Thank you so much and hope to see you soon.